Dear viewers, welcome you all to our show OSA, that is Orthopedic Solution Academy. Hope you all are well during this overcoming situation of COVID-19. Dear viewers, today our topic is osteomyelitis of ankle, Ilizarov salvage techniques. A very important topic today. And the speaker is Dr. Anatoly from Kurgan, Russia. Dear viewers, we have learned academic expert from all around the world. One of them is Professor Novikov sir. Sir, welcome. And Dr. Anatoly sir, please welcome to our show, Orthopedic Solution Academy.
Hello, everybody.
Good afternoon.
Hello. Good afternoon, sir. Dear viewers, we have learned academic expert from Bangladesh, the legendary Elizabeth surgeon from Bangladesh, the one and only Professor Mofakkarul Bari sir. I would like to request Professor Mofakkarul Bari sir to join with us.
Thank
Good
you. Thank
afternoon,
you
sir.
very much. Good afternoon.
Thank you very much, sir, for joining with us. Dear viewers, we have another academic expert from Kurdistan, Iraq, Professor Omar sir. I would like to request Professor Omar sir to join with us. Sir, would you please join with us? Thank you very much, sir. Dear viewers, we have another enthusiastic academic expert from Patna, India. That is Dr. Shamsul Huda sir. I would like to request Dr. Shamsul Huda sir to join the Orthopedic Solution Academy.
Thank you, Dr. Tamir.
Good afternoon, sir. Dear viewers, we don't want to waste any more time as because of everybody is waiting for our new topic, that is osteomyelitis of ankle, Ilizarov salvage technique. I would like to request our honorable speaker, Dr. Anatoly sir, to start his magnificent presentation. And the topic is osteomyelitis of ankle, Ilizarov salvage technique.
Dear colleagues, osteomyelitis of the ankle, it's very common problem. It's very in our practice we find every year more than 50 cases in a year, and from last 10 years in our department was treated more than 300 cases with ankle joint osteomyelitis. So most common etiology of osteomyelitis in ankle joints, there is trauma, post-traumatic. So and but in 29% we can find that diabetes and neurogenic disorders can be provide problems with ankle joint, and because that comorbidities can start infection process in the ankle joint. But if we look in the X-ray, we can find that in 55% patient cases had only destruction of the articular surfaces, and in 22% patients had defect of the distal articular side of the tibia, and in 14% talus defect, and in 12% combined big defects with the defect more than 6 centimeters. So our aims for treatment of that patients, first there is a suppression of infection, and second there is recovery function of limb. Typical our protocol of treatment that patients with infection with osteomyelitis include preoperative period where we do preparation for surgical interventions, and second stage revision where we do debridement, next stage reconstruction where we do orthopedic recovery of limb, and the fixation stage when patient can walk in Ilizarov fixator with give a functional loading on his limb. So influencing factors on the treatment protocol There is the age of patient, clinical manifestation of the disease, previous treatment, comorbid background, psycho-emotional mood of the patient. So, what types of techniques for ankle reconstruction by Ilizarov? Of course, most common technique there is ankle arthrodesis by with using monolocal technique. That technique we used in 79% cases. So here as we can include closed monolocal, just compression method for ankle arthrodesis. Bilocal technique when we do first stage debridement and in second stage after debridement after distal proximal side tibial osteotomy healing bone defect. There is bilocal technique and creation of new arthrosis. There is our young technique for the technique for we create for safe function of function of ankle joint. So, and one of the typical example when we do of monolocal osteosynthesis of patient that patient with open dislocation and fracture of talus and and after that trauma patient was started infection process, osteomyelitis of the talus, and with that clinical and the X-ray view, patient was admitted in our department and was done debridement and standard arthrodesis of ankle by Ilizarov with using typical standard technique, monolocal, just compression. And after after that fixation, totally time of fixation in the Ilizarov frame was 2 months. And after that, after removal device, patient don't have recurrence of infection and can walk in with lateral shortening and with full pressure on his operated limb. And if we're talking about the total results, we analyzed our results of patients with ankle arthrodesis. Totally, we had in 86% ankylosis of ankle joint, and in 9% non-union, and in 5% near arthrosis. But there is we do, as I told before, the special technique we don't include there is in better result like in non-union. So. Which reasons for the creation of non-union in our experience? In 10 cases, we find that reason was diabetes. In 15 cases, neurological disorders and other complications was defined in 6 cases. So totally with non-union, we had 31 cases. And when we started analyze all the cases, we find that only in 14 cases had a pain, deformation, wounds, or fistulas, and local inflammation, totally recurrence of infection. But in 17 cases, patients don't have that manifestations. Patients have had a good function of the ankle joint place, don't have deformity or recurrence of infection or everything, and they good. They are used their operated limb without something troubles. And but 14 cases because they had manifestation, pain or recurrence of infection. We try to do debridement and arthrodesis again, and totally we had good result in that 14 cases. We take arthrodesis, and finally, so if we're talking about non-union cases, here is in that case I try to show another one case with non-union. Patient was admitted in our department with that local and X review, with fistulas, with inflammation on ankle joint location. Uh, in first stage, we was made debridement, and we tried to do arthrodesis firstly, and we made in Ilizarov frame compression for creation of arthrodesis. But after removal device unsuccessfully, we don't take ankylosis of joint. But after that, patient have a function, and very good function, as you can see in that picture is. So, and one important that patient don't feel a pain and don't feel a recurrence of inflammation or infection. And the patient said to us that very good, that condition is very good for him, and that the patient don't want to do another one surgery for stabilization of the joint. And we saw that that patient like a complication, but patient was very happy when take that result. So, and what is the indication for using neararthrosis technique? There is not active lifestyle of patient, minimal size of bone defect, non-complicated comorbidities, normal body weight, compliance of patients, and one important, there is a law for adventure of the surgeon. So, and what is a typical technique protocol which we started to use it after the previous case? First, lateral salvage access for ankle with osteotomy of lateral malleolus and release lateral malleolus with especially with safe all tendons all for um, for creation of stability of ankle joint in future. Second, there is a hinge type resection of articular surfaces of tibia and talus. And third, there is osteosynthesis by Ilizarov, suture and wound, creation of free space 10 millimeters by distraction, and totally time for fixation in our protocol in Ilizarov frame only 1 month, not more. So totally with neararthrosis, we had 17 cases. Middle time of fixation in Ilizarov frame 43 years plus minus 5 days. 5 days. In 88%, we had a good function, flexible ankle joint location. but in 12 percentage patient after removal external device, patient take a union of that like arthrodesis. So, and one of the case of knee arthrosis patient with ankle joint infection with fistulas was admitted in our department with that X-ray view, and we was done our technique, our method, our technique was done creation of knee arthrosis, and in the result, patient have a good function. And here is in the movie we can see how patient can use his leg. Patient used normal shoes, walking without some crutches, and patient don't have a pain, and very happy after the surgery. So, and finally, compliance of patient for treatment, the comorbid background, local status is the key factors that can be determining treatment and outcomes. The creation of congruence between the bones of the ankle joint ensures the achievement of the set clinical goals and is the prevention of recurrence of infection. And the absence of pain, recurrence of purulent inflammation, the remaining range of motion in case of failed arthrodesis of ankle joint are not always an absolute indication for repeated arthrodesis. In that movie, patient can use external device with his vehicle. Yeah. And for collaboration, you can use that links. So thank you for attention.
Thank you very much, Dr. Anatoly sir, for your excellent presentation. Now, I would like to request our honorable academic expert to say something regarding the new presentation. I would like to request Professor Mofakrul Bari sir to share his vast knowledge regarding the presentation, sir. Professor Mofakrul Bari sir, would you please? Please unmute Professor Mofakrul Bari sir.
And Omar and Shamsulhuda, very good topic. We are facing here in my country also a lot of cases with this ankle infection in diabetic patient, in non-diabetic patient. And sometimes it is very difficult to make the patient understand. Sometimes they want to, instead of doing arthrodesis, they want arthrodesis or mobile joint. And in your cases, formation of new arthrosis, it is very good, very good. And especially what I have seen for the diabetic patient, you cannot get all the time full arthrodesis. Fibrous ankylosis is getting in diabetic patients in all the time, fibrous ankylosis. So this is a very interesting topic that you have already delivered. It's good. Thank you very much. Learned a lot of things from your these cases. And one question only, and my observation regarding your close technique, 1% without opening anything. How do you go for that? You are not denuding anything in the lower tibia or upper talus or in the calcaneum. In 1% case, you have shown that you are doing the closed method, not opening. How you do that? In what cases? What is the indication?
For using that close technique, we find patients which X-ray pictures show it to us is resorption of ankle joint bones, destruction, and especially that here is that patient don't have active infection process. That means that before that operation, that surgery, patient is not have open fistulas, open wounds, or everything like that. And in that cases, we nothing to do with the bones by open. We only put Ilizarov frame, Ilizarov fixator, and do just compression on ankle joint location. Only closed and without intervention in ankle joint bones surface. So only closed compression. Yeah,
No,
like that.
if you get the fragmented bones around the ankle, sometimes you get the fragmented bones around the ankle. How you manage them?
Here is when we have angle, we do a compression, and after 20 days after that compression, we started just a little bit lengthening with deformity correction of that angle. And totally, in all cases which we was treated before, we take from that place bone regeneration. And in that bone regeneration, with that bone regeneration, we do correction of deformity and normal access of normal alignments of ankle joint or alignments of leg, and something like that. About that technique, we are 2 years ago we are published in BGG journal article. You can find that here. In that article, we show it all details of that technique.
Okay, thank you. Thank you.
Thank you very much, sir, for a nice question. Now, I would like to request Dr. Shamsul Huda sir to say something regarding the presentation, sir, please.
Thank you, Dr. Tanvir. Congratulations, Dr. Nathale, for a wonderful presentation on difficult cases and in closed method. I just have one question, that after healing, how much is the rate of relapse of infections in these cases? Recurrence.
Recurrence of infection.
Yeah.
Recurrence of infection after non-union technique. We don't have no one because in the debridement stage of surgery, we was made maximal resection of all osteophytes, all necrotic bones on articular surface, and one special that we create hinge surfaces on articular place of joint, and that hinge surfaces can provide some how to say some creation of some blood in some
like bleeding.
Like bleeding, yeah. And because we don't have recurrence of infection in that case. But when we will use the technique more and more, I think we will find some infection. But I think here is only a success for us because we don't have infections only. Yeah.
Thank you. Yeah, thanks a lot. Thanks a lot. It's because we get so many cases of this diabetic cases, complicated cases in our clinic. Variety of cases we have to do open debridement also. My next question is that what is the bracing protocol after removal of Ilizarov in your cases? The bracing protocol.
After removal cases, after removal fixator, patient is start working with physiotherapist. Patient start walking with a little bit pressure on his limb and for creation of flexible in the joint place. So something like that. And with the time, he should be walking more and more, but gradually.
Thank you. Thanks a lot.
Thank you very much, Dr. Shamsuludda sir, for your nice questions. Dr. Anatoli sir, I have one question. You have mentioned in your presentation that sometimes you do open ways osteotomy in lateral malleolus, and after that, do you fix the lateral malleolus by screw, or you use Ilizarov wire to fix the lateral malleolus, or you leave it alone?
For fixation, lateral malleolus, we used only K-wires by Ilizarov only, and for union of lateral malleolus, enough 1 month in our experience.
Okay. Your experience. Okay, thank you, sir. Thank you very much. Professor Omar, sir, can you share your knowledge with us? Sir, we can't hear you, sir. I think there is a network problem there. So we should move forward to Professor Novikov, sir, as because of we can't hear Professor Omar, sir. I would like to request Professor Novikov, sir, to say something and share his knowledge regarding the presentation. Professor Novikov, sir, please.
I want to say thank you very much for my young colleague, because today we can see excellent experience and new step of treatment. Very difficult cases in the Russia, I think, all of the world. And you see, very interesting situation when sometimes all of doctor think about difficulties, about complications, but patient absolutely happy with final result. And just now we can say about another view when we talk about final result. We can see with plan of for arthrodesis, patient has function of ankle joint and was more than happy. And second point, today we can see excellent examples with effect of Ilizarov when compression, sometimes distractions, give us absolutely a new tissue, because all tissue doctor remove, and body of patient grow absolutely new fantastic tissue, and this is tissue give possibilities for patient for function of ankle joint, very important of joint for normal life. And this is another side of magic Ilizarov, when we can say just now we only maybe read first page of effect of Ilizarov, the grand book of knowledge, philosophy, everything. And effect of Ilizarov in the future show us another fantastic possibilities for patient. And today I am more than happy, because now we have special department for treatment heavy cases with food. And I have one question. How many patients, Dr. Sudnitsin, have antibiotics treatment after surgery or before surgery? You show more than 300 patients. And who is from all of them need prescription of antibiotics? And this patient need antibiotics or not?
Totally, we used antibiotic therapy because we have our standard protocol for treatment all patients with osteomyelitis. And we should give antibiotic therapy for every patient with osteomyelitis, with infection process. But totally middle time of using antibiotic in our experience, there is not more 15 days totally after surgery. And before surgery, we don't give antibiotic therapy usually. And what about that cases, that patients with knee arthrosis after removal device and we don't give antibiotic therapy after that. Only by standard standard protocol, only 15 days after first surgery after debridement. That's all.
Okay. Thank you. Thank you very much. Thank you, Professor Navikov, sir, for your nice questions and sharing your knowledge. Dr. Anatoli, sir, I have one last question regarding the compression and distraction. Do you maintain any special protocol that how many days you will give compression and how many days you will give distraction? And when you will start the compression and when you will start the distraction? Is there any definite protocol that you maintain?
Sure.
Yes, for every Z technique, we have a standard protocol for compression distraction. For example, for monolocal osteosynthesis, for monolocal arthrodesis, stand like a open, like a closed. After in surgery, in a surgery after Ilizarov, when we make Ilizarov device on surgery table, we give compression like 5 millimeters by one moment, and after that time, every 10 days, every 10 day, we patients should be give compression 1 millimeter every 10 day in no time of fixation. And totally, if we're talking about, for example, 2 months of fixation for arthrodesis of ankle joint, patient should be gives compression like 8 millimeters. So if we're talking about technique by local osteosynthesis, when we have bone defect after debridement in ankle joint location, and of course after for healing that bone defect, and when we do osteotomy in proximal side of tibia, patient should be lens should be healed that bone defect with using 1 millimeter per day per day for healing that defect, and the patient should be give that distraction every time when we before he stopped, before he is healed that defect, and after destruction, patient and when patient have a good bone contact in between calcaneum, like for example calcaneum and tibia, in that place between that bones, patient should be given 1 millimeter per 10 days, like in previous case, for all time of fixation, for creation of good fusion of, of that bones. And if we're talking about neoarthrosis cases, here is we give just 10 millimeters on the surgery time, and there is enough. So
Okay, thank you, sir. Thank you very much. Then it
Sir,
is.
we have Dr. Hariprasad sir, our eminent orthopedic and trauma surgeon here with me. Just want to say hello to everybody.
Hello, sir. Hello, welcome. Welcome to our show.
Very
It's
nice.
a it's
Very
it's a
nice.
great pleasure for us. Thank you very much, sir. It's a great pleasure for us that you have joined with us.
Yes. Thank you.
Thank you very much, sir. And I would like to thank Dr. Anatoli, sir, for your excellent presentation and for your latest information regarding the ankle osteomyelitis. I would like to thank all of our academic faculties and our new guests from India. Very many thanks everybody for joining with Orthopedic Solution Academy. And I would like to thank Rajtv for helping us to arrange this type of academic program, and definitely Renata Pharmaceuticals Limited for sponsoring our program. Dear viewers, I'm Dr. Mohd Tanvir Ashraf saying bye-bye today, and hope we'll meet you in the coming Friday with another magical Ilizarov topic. Till then, I would like to say bye-bye to all of you. Bye-bye. Bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.